Are you able to see now?
Yes, I can.
Yeah, good. Sorry about that.
No problem. So the CT confirms the mass that we saw in the anterior mediastinum. It appears to be heterogeneous with fatty and soft tissue density. I can't see any focal calcification, and the lungs, I can't see any associated pleural effusion or lung abnormalities. So given the fatty density, my top differential will be a teratoma.
Yeah, very good. That's what it is. Yeah. So it's very easy to address differentials of mediastinal masses if you divide it like what Chapman has done. So in the superior part of anterior mediastinum, realistically, apart from vascular structures, which you will be readily able to identify, there are only three differentials: goiter, lymphadenopathy, or thymic tumor. Is that a good way to understand this? In the anterior superior mediastinum, anterior part of the anterior mediastinum above the blood vessels, there are only three differentials that you should need to think of: goiter, lymphadenopathy, and thymic tumor. Vessels you will be able to separately identify anyway. Now, in the anterior mediastinum, in the middle part, there are only three abnormalities you need to think about: germ cell tumor, like in this case, or a thymic tumor. Actually, two only. And the sternal lesion is the third one, but you will be able to see the bone involvement in that. So there are only two abnormalities, realistically, that you have to keep in mind when you are looking at differentials of a mediastinal mass in the middle part of anterior mediastinum. Now coming to the anterior mediastinum lower part, pericardial fat pad, diaphragmatic hump, Morgagni hernia, pericardial cyst. So put the pericardium together, pericardial cyst and pericardial fat, and then the diaphragm together, diaphragmatic hump or a Morgagni hernia. So there aren't a lot of differentials to keep in mind when you are trying to address and navigate your way through differentials of mediastinal lesions. Similarly, in posterior mediastinum, there aren't that many differentials. So Chapman has divided the posterior mediastinum into 1, 2, 3 like this. So one being paravertebral. So you exclude the bony abnormality, which you will be readily able to identify because there will be bony destruction and so on. So if you exclude the bony abnormalities, which is bony metastasis, bony myeloma, or an abscess related to the bone or paraspinal structure, there are only two differentials: extramedullary hematopoiesis and a neurogenic tumor. There are only two differentials outside the bony and paraspinal tissue that you need to consider in the posterior mediastinum. That is neurogenic tumor and extramedullary hematopoiesis. Now coming to the anterior part of posterior mediastinum, there are only two. There is only one, to be honest: esophagus, achillocardia, and dilated aorta. Now in the lower part of posterior mediastinum, here anterior to the spine, there is only hiatus hernia and Boctalic hernia, which are both diaphragmatic hernias. So there aren't quite a lot of differentials if you keep this concept in mind. This is the third part of mediastinum, which is between anterior and posterior mediastinum, which involves the heart, blood vessels, and the major airway. And the differentials are again quite clear: a bronchogenic cancer from a major bronchus, a bronchogenic cyst, a vascular abnormality, or lymphadenopathy. Do you want to try this X-ray?
Yeah, sure. So frontal radiograph of the chest in an adult patient. There's loss of volume in the right lung and what appears to be elevation of the right elevation of the right hemidiaphragm. We've moved on to a CT chest, which shows...
That was by error. I didn't want to move out. There was one sign that I wanted you to pick up in that X-ray. Let me just go back to that. Yeah, sorry about that. Let me share this again. Can you see the X-ray now?
Yes, I can see the X-ray.
Yeah.
So the right hemidiaphragm appears to be elevated, and there's increased density behind the hemidiaphragm. There's also foci.
Are you referring to this?
Yeah.
So that is the point that I wanted you to see. Have you ever seen the dome of diaphragm crossing the spine?
No.
So where is the dome of diaphragm? On the left side? You can see the dome of diaphragm coming here, and it attaches to the paraspinal structures by the diaphragmatic crus. It is a linear soft tissue structure that you identify on CT. So it does not cross the spine. So what's happening on the opacity on the right side?
So it crosses the spine.
Crosses the spine. So that's not the dome of diaphragm, although it seems to be the case. The dome of diaphragm is somewhere here. Just pushed down by a mass. Yeah. So just to give you that concept of dome of diaphragm and its anatomy, I will give you a CT now for the same patient.
So in the CT, there's a low attenuation mass taking up the majority of the right lung, with some vessels passing through it. There isn't any associated bony changes. In my routine practice, I would measure the Hounsfield unit because it looks like it is of fatty density.
It is fatty density. This is a rare condition. It's not a common condition that you can make a diagnosis. The point that I want you to understand is that the lesion is attached to the space anterior to the heart here. That is the space occupied by?
So the anterior mediastinum, so it can be mediastinal lipomatosis.
Right. I mean, this space anterior to the heart is occupied by what structure?
Anterior to the heart?
Yeah.
So the thymus?
Yeah. So this is a lesion arising from the thymus, and is so big it has got a peduncle and it is spreading into the chest. So it's a very rare tumor. So it's a thymolipoma from the thymolipoma. Yeah. Yeah, myelolipoma, very similar. So thymolipoma or myelolipoma, I can't remember. So it's a fatty tumor from the thymus. Good. So next one.
Okay, frontal radiograph of the chest. So the lungs appear to be clear.
Good.
There's possibly increased thickening in the superior aspect of the mediastinum. There's an azygos lobe that I can see, but there's increased thickening in the right and left. The right paratracheal stripe appears to be thickened.
Yeah.
And
so there is mediastinal widening on the right side. To keep it simple, I would just describe it as mediastinal widening on the right side. Okay. That's not normal. That opacity is not normal. You should see the hilum. So there is lymphadenopathy, most probably in the right tracheobronchial angle. Yeah.
Mm-hmm. Yeah.
Lateral shows soft tissue there. And you do CT, of course. When you see mediastinal widening, you need to do CT. And do you want to have a go at the CT?
Yeah, sure. So the CT shows a lobulated, well-defined mass in the superior retrosternal portion of the mediastinum. It doesn't appear to obstruct any of the vessels. I can't see any calcification within the lesion.
Yeah. So
my differentials for this would include lymphoma. As the most likely differential, and I'd recommend obtaining a soft tissue biopsy.
So what were the differentials that we said taking it from Chapman, of a anterior mediastinal lesion in the superior and middle region of mediastinum.
So this
is not a vascular structure that we know. This is not a aneurysm from the brachiocephalic artery or an aortic arch aneurysm. This is a soft tissue structure. So there were only 3 things that you have to keep in mind. We said.
So it can be a thyroid goiter, which is a thyroid. So check if it's more superiorly.
Yeah, it can be a bit more superior. Yeah.
It can also be nodes,
lymph nodes. Or thymic tumor. Those are the only 3 things that you have to keep in mind in this region. As you correctly said, it's a bit unlikely to be a goiter because the epicenter of mass is quite a bit low. Number 1. Number 2, goiters have typical appearance. So the realistically 2 differentials. One is a thymic tumor, and the other is a lymph nodal condition like lymphoma. Now, if you look at lymphoma, they are usually the lymph nodal pattern will be identifiable rather than one large single soft tissue mass. So with this one large single soft tissue mass, I would consider thymic tumor first. It's quite simple, isn't it? There are only 3 things to keep in mind: lymph nodal soft tissue, thymic tumor, goiter. It's not goiter because it's quite high. It's a bit too low. It's less likely to be a lymph nodal soft tissue mass, although still possible, because we are seeing one large soft tissue mass than multiple conglomerate lymph nodes. It's actually an invasive thymoma. It's invasive because the margins are poorly defined and it's probably infiltrating into the vascular structures. Okay, but that diagnosis between an invasive thymoma and benign thymoma is a post-op diagnosis depending on capsular invasion. But this quite clearly has got invasive features. Next one.
So frontal radiograph of the chest, and there's thickening of the right paratracheal stripe. The mass area appears to extend above the clavicle, and the lateral border appears to be well defined, making it thyrocervical sign positive, meaning it's either in the posterior or middle mediastinum, but not in the anterior mediastinum.
Not in the anterior mediastinum. So I hope everybody has heard that. The lateral margin is visible above the superior margin of clavicle, which makes it not in the anterior mediastinum because anterior mediastinum stops at the clavicle. So it's either in the posterior mediastinum, most commonly it's in the posterior mediastinum, or in the neck. This is unlikely to be in the neck because we know that major part of this abnormality is below the clavicle. So this can only be a posterior mediastinal mass lesion because cervicothoracic sign is positive. That is, lateral margin of the lesion is visualized above the superior margin of clavicle. So that's a CT which shows that mass lesion. It's in the epicenter is in the posterior mediastinum, but then mediastinal tumors don't know that we have divided them into compartments, so they grow everywhere. So primarily a posterior mediastinal lesion going into the middle mediastinum, as you can see on MRI and CT. Diagnosis?
So it appears to be iso-intense to the muscle on the sagittal MR and soft tissue density, which extends
in posterior mediastinum. We made it very simple. In posterior mediastinum, the first question that we ask is it from the bone or related to the paraspinal structure? Yes or no? Is it from the bone?
No, it's not from the bone.
No, it's in the posterior mediastinum. It's not in the bone. If it's not in the bone, there are only 2 differentials to be considered. What were they?
Ganglioneuroma was one, I think.
Ganglioneuroma or a neurogenic tumor. Like a can be a neurofibroma. Although Chapman gives ganglioneuroma, but it can be a neurogenic. I would just say neurogenic tumor and don't bother anything further than that. And
I think abscess was one. extra
Yeah, but
medullary
abscess is usually related to the bone, isn't it? Abscess in a posterior mediastinum usually comes from the spondylitis or discitis. So I would put it along with the bones, and there will be bony destruction and so on. So the second differential, where the bone is completely normal in a posterior mediastinum, is extramedullary hematopoiesis. It's very simple. It can only be a neurogenic tumor, or it can be an extramedullary hematopoiesis in the posterior mediastinum if it's not from the bone or related to the bone, like a myeloma or metastasis or abscess. So this is actually a neurogenic tumor. Cervicothoracic sign, we have described this. If the mass extends above the superior margin of clavicle on X-ray, then it's either in the neck or in the posterior mediastinum, most usually posterior mediastinum. This is another case similar. As you can see, the cervicothoracic sign positive, posterior mediastinal lesion. We'll skip that and go to the next one.
Okay, so onto radiograph of the chest. There is a left retrocardiac shadow.
Very good, yeah.
Lines, and it looks like it's basically coming adjacent to the paravertebral line, so it looks like it's a posterior mediastinal mass.
Yeah. So that's very good. Posterior mediastinal mass has got a broad base to the spine. If it was in the lung, you would have seen some lung, or at least some angle with the mediastinal, the paraspinal border. CT.
Okay, so in the selected CT images, it appears to be arising from the lateral descending thoracic aorta, and it appears to have calcification within its wall. So I'd be concerned about a vascular.
Yeah, like a saccular aneurysm. Yeah, that's fine.
Yeah.
But this is actually outside the aorta, although the CT has gone into venous phase, so you're confusing it. So it's outside the aorta in the posterior mediastinum. Diagnosis?
So I can't see any bony changes. So
yeah,
again, it's the same two differentials: neurogenic tumor, extramedullary hematopoiesis.
Exactly. Yeah, that's all we have. If it's outside the bone, and if it's outside the aorta, and it's outside the esophagus, that's a neurogenic tumor. So again, posterior mediastinum, just to revise, neurogenic tumor or extramedullary hematopoiesis, and in the bone, Mets, myeloma, or abscess, all these things. Again, yeah. Next one. How many? We have done 6 cases. Let's do a few more, and then we will swap the viva candidate.
Okay. So in this frontal radiograph, there is a well-defined mass in the left superior paravertebral region. It doesn't appear to extend above the superior clavicle. And it appears to be, I can't see any calcification within it, so it appears to be broad-based with the mediastinum, so there's left mediastinal widening.
Yeah.
In keeping with the mediastinal mass. I'm trying to see if I can locate this mass. Appears to be a superior anterior mediastinal mass, because I can see the silhouette of the aortic arch separate to the mass, and I can't see any associated posterior rib changes.
So can you compare the width of the ribs, posterior ribs on the left side?
So I think maybe on the left hand side the ribs are slightly wider.
Compare that rib, and what is happening to this rib?
Right, okay, yeah. So this rib looks like it's slightly thinned compared to the other ribs. So there looks like there's some splaying of that rib space with some scalloping.
Yeah, so there is scalloping. That's another thing that you have to look for. If you identify a mediastinal lesion, look for scalloping of the ribs, as you see in this case. And so this is a
posterior mediastinal mass.
Posterior mediastinal mass lesion, most commonly a neurogenic tumor scalloping the rib. Next one.
So in this radiograph, in the superior mediastinum, there again appears to be something widening the mediastinum bilaterally, both on the left and the right hand side.
Yeah,
the image is a bit
widening of the mediastinum extending to both sides. That's all you can say on this. Yeah, widening of the mediastinum. CT.
So the CT confirms the mass to be within the predominantly in the posterior or middle mediastinum, actually, because I think there's a gastric tube.
Yeah.
So the esophagus, so it appears to be anterior to the esophagus and posterior to the heart. The lesion is of homogeneous low attenuation.
And I can say that was cystic density.
Yeah. So my differential would include a foregut duplication cyst.
Yeah.
And there appears to be some consolidation in the right.
Yeah. Or foregut duplication cyst or bronchogenic cyst.
So it can be bronchogenic or esophageal duplication cyst.
Yeah. So this is middle mediastinum, and as we know, middle mediastinal differentials are quite few, which is either arising from the trachea or bronchus. This case, like a bronchogenic cyst or a cancer arising from the trachea or bronchus, or lymph node or blood vessel structures. It's not blood vessel structures, it's not lymph node, so it's a bronchogenic cyst. Yeah.
Okay, so there's increased opacification behind the left heart border. The rest of the lungs and pleura appear to be clear. I'm trying to see if there's any calcification within the wall of this lesion, which doesn't appear to have it. The highlight appears to be normal, so this is most likely a posterior mediastinal mass.
Yeah, okay, but the X-ray stays there in the exam. I can confirm that lungs and hyla are fine.
Okay, so having a look at the bones. So there appears to be increased density in one of the right posterior ribs. I'm not sure if that's projectional.
Yeah, that's projectional. Ignore that.
Fine. Having a look at the rib space, appears to be preserved.
How does the clavicle look like? What's happening to the endosteal margins of the clavicle? Are they normal?
No, so they appear to be slightly expanded.
Yeah.
And
so if you put the differentials of a posterior mediastinal mass, we know that differentials of a posterior mediastinal mass are?
So this is most likely to be extramedullary hematopoiesis.
Very good. Absolutely. So this is a case of thalassemia, because bones are, and there is endosteal scalloping because of diaphyseal widening. Even if you look at the ribs, they are also a bit wide. They're a bit wide. The ribs are wide. Yeah? And there is a posterior mediastinal mass, which is extramedullary hematopoiesis in a case of thalassemia. So that's how it appears. Extramedullary hematopoiesis. Quite simple, isn't it? Neurogenic tumor or extramedullary hematopoiesis. You put the bone findings together, it's extramedullary hematopoiesis. You put rib scalloping, then that's a neurogenic tumor, neurofibroma. Do you want to change into another candidate, or are you good to go?
I don't mind.
Are you good? Yeah? Continue, yeah?
Okay. So we have here a nuclear medicine study of the neck, which shows uptake in the thyroid as well as uptake in a with focal uptake, tracer uptake more inferiorly, and given that it's taking a similar level of uptake to the thyroid, to the ectopic thyroid as a possible cause for this, I'd recommend ultrasound imaging to assess this nodule.
Ultrasound of the neck is completely normal.
So maybe a chest X-ray or a CT to see if they have an enlargement of the. A CT would probably give you the answer to see if this is ectopic thyroid tissue.
What does the third image show? That my arrow is pointing. What has happened to thyroid gland in the third image?
So it's so the trace activity appears to have reduced, but in the inferior nodule, it continues to take up tracer. So maybe a parathyroid adenoma is the other possibility, given that there isn't any washout of tracer. So I would
parathyroid adenoma where?
In the it's an inferior to the thyroid, so left.
How inferior to the thyroid? How inferior to the thyroid?
So a few centimeters more inferior to the thyroid, focus of thyroid uptake.
Yeah, it's in the chest, isn't it? So that's the neck. That's the neck. Yeah, that's the neck, and this is actually in the chest. So that's a ectopic parathyroid adenoma.
Yeah.
So that's the liver. You see that you're seeing part of the liver uptake. You're seeing part of the heart. So that's ectopic parathyroid adenoma, and the study is
system AB.
Yeah. So this is a system AB and this is a system AB PET technitate scan. Okay. You inject system AB and PET technitate. PET technitate is taken up by thyroid, while a system AB is taken up by abnormal parathyroid and thyroid. Then you subtract the PET technitate image from the system AB image, then you will get only the parathyroid. Okay, so you can follow it up by a SPECT CT, which is a combination of the nuclear medicine and CT, and you can see it's in the chest, abnormal uptake parathyroid in the ectopic parathyroid gland in the anterior mediastinum. I think we will change to the next person. I think the next participant, I think number 1 had to leave, so it will be number 2. So number 7, are there 8 candidates or 7 candidates? I'm not quite sure. Let me just check a look.
Number 8 is also there. Excuse me, this is me here. Number 8 is there. Number 8.
Yeah, thank you. Then we'll go to number 8. Thank you, number 7. Can you mute yourself? And number 8,
hello.
Can you raise your hand, please?
Yeah, I'm here.
Have you? Just a second.
Can you hear me?
Yeah, I can hear you. That's very good. So this X-ray is for you.
Okay, thank you. This is an AP erect radiograph of an adult patient. The most apparent abnormality is the presence of gas throughout the soft tissue, in keeping with surgical emphysema. I wonder if this is a traumatic injury to the patient, or in terms of looking at the lungs and the mediastinum, I see a median stenotomy virus. The lungs appear well inflated, actually. I don't see an obvious pneumothorax bilaterally, but I'll be concerned that there must be some injury to the lungs causing this very florid surgical.
Yeah. So what was your comment about mediastinum? I didn't get that. Sorry.
Sorry, actually, I haven't said much about the mediastinum.
Okay.
So looking at the mediastinum itself, there may possibly be some air around the aortic knuckle and extending upwards.
Very good. Yeah. So there is air around the aortic knuckle and extending upwards around the paraspinal line. So this is.
So this is in keeping with pneumomediastinum and florid.
Yeah, and florid surgical emphysema. I just wanted you to pick up the pneumomediastinum. So look for air around the aortic knuckle, look for air around the paraspinal structures, along the cardiac margins, on both sides, and so on. So this is post cardiac pacemaker X-ray.
Okay, this is a frontal chest radiograph of an adult patient. There is a ICD device in situ. There are some prone changes in the left base, but these appear chronic. Given that it's post pacemaker insertion, looking for any of his pneumothoraces. It's not very, I mean, it goes on and off in terms of being blurred, but I don't see any large pneumothoraces, especially on the left side. I'm looking at the heart itself. There appears to be a bit more increased lucency projected over the left side of the heart. I wonder if there is possibly some gas within the pericardium. Okay, so and being pointed to the left side of the aortic knuckle, I think there's increased lucency, which will be in keeping with an injury to the what do you call it, the mediastinum, therefore pneumomediastinum is present.
Yeah, so there is pneumomediastinum here. Again, loosened area along the aortic knuckle. In the next X-ray, it's much more obvious.
Okay.
Yeah.
Okay, this is a frontal chest radiograph again of an adult patient. The trachea is relatively central. Looking at the mediastinum, I don't see any obvious pneumomediastinum.
Yeah, there's no pneumomediastinum in this X-ray.
The lungs are.
Yeah, ignore the lungs.
Okay. This is so. Looking at the bones.
Bones are fine.
Okay. So looking below the diaphragm and in my review areas as well, there is a slight hump in the left side. It's asymmetrical compared to the right in the diaphragm, along the diaphragmatic line.
Yeah.
So there's an increased density, which is fairly well circumscribed, and I can see the left hemidiaphragm going across it actually. So I wonder if this would be the posterior aspect of the lung, or possibly a hernia of some sort, probably a Morgagni's hernia.
I would say Boctalic hernia, because Morgagni is anterior, isn't it? You won't be able to speak.
Boctalic hernia,
yeah. Yeah, Boctalic diaphragmatic hernia. Just keep it as simple and say diaphragmatic hernia, then you have covered both Morgagni and Boctalic.
Okay.
Yeah. So basically a defect in the diaphragm through which something from the tummy is going up into the chest, into the posterior mediastinum.
Okay. So this is a frontal chest radiograph. The superior mediastinum is abnormal. There's increased lucency, which areas of punctate lucencies actually, and increased density and irregular edge on the right side. So, I mean, appearance is suggestive of previous surgery, possibly a gastric pull-up or colonic interposition. I'd like to look at previous imaging. And
how old do you think the patient is?
I think
any calcification of the costal cartilages?
I do not see any calcification of the costal cartilages, but okay. So there's no previous surgery.
What about gastric air bubble? Can you see gastric air bubble?
I do actually see the gastric air bubble as well. So I'll just take a step back. I don't think this is post-surgical appearances. So the mediastinum has got an increased density more on the right side throughout the whole right chest, and there appears to be some debris or material within this structure. So I think this is a dilated. I mean, initially I thought this would be a dilated esophagus.
Yeah. Then what made you think against that? This is a dilated esophagus.
Yeah.
Should be straight. No. Is there anything that made you think otherwise? That's fine. I'm just thinking out loud. How? Yeah. This is just achalasia cardia. Young man, you know that primary eclampsia usually happens in young people, and it's a dilated, distended esophagus. Stomach air bubble is in its normal position.
Yep.
Yeah, good. Now this is another one. Yeah, but we have moved on from mediastinum now.
Yep. So this is a frontal chest radiograph of an adult patient. I mean, there's very high density in the middle, so I can't really see the vertebral body behind the heart. The hilar appears unremarkable. The left is higher than the right, which is expected. I'm being directed to the left hilar. So I think, given that the abnormality could probably be there, I'm expecting a possible hilar lesion.
Yeah, that's definitely a consideration. But a hilar lesion, you know, by definition, hilum is the point between where the vessels cross, and it's somewhere here, which is somewhere here. But you can see that this abnormal opacity is lateral to the hilum.
Okay.
So you can see a air space between the hilum and the abnormality, just to get your anatomy, you know, a bit more orientated. So a hilar lesion would be somewhere here. It can appear as a bulky hilum, but this is just outside the hilum. Yeah.
Okay. So given that there's a density which is lateral to the left hilum,
it's a bit tricky. It's very tricky. You have to put a lot of things that we learned today into action. Can you compare the blood vessels in the upper lungs on both sides and make a comment? The blood vessels.
I'm getting a very easy image. In this case, I would expect if there is a lesion which is causing obstruction of any sort or consolidative changes, there will be.
No, just comment on the intrapulmonary blood vascular structures in the left upper lobe, left upper lung and right upper lung. Just compare the vessels here and vessels here.
I think they're a bit more prominent on the left.
You mean the vessels are prominent on the left or sparse on the left? So you can see the blood vessels all here. Are you seeing similar blood vessels here?
No, I'm just seeing very grey pixelated images, unfortunately. I think it's probably something on my side.
Ah, right. So probably that's a bit difficult. This is really, you really have to view it on a large screen with maximum density. So what has happened is that the vascular structures are sparse here in comparison to all the branching blood vessels on the right side. That is because the left upper lobe is abnormal. Okay, so we know that whenever the vascularity reduces, that lung is abnormal. Yeah, when lung can still have aeration, but the hallmark for an abnormal lung is poor, sparse vascularity. The vascularity in the left lung is reduced, and we have this oblong opacity in the left upper lobe, which is actually that's a bit of a tricky diagnosis. But bronchial atresia is an abnormality that can typically present like this. That's most commonly in the left upper lobe, an oblong opacity near the hilum, which is actually a blocked mucus-filled bronchus and sparsely aerated upper lobe, left upper lobe. So this is a bronchial atresia. The same patients, VQ scan. Now, which one is ventilation and which one is perfusion? The more I'm not a nuclear medicine radiologist, but that's how I identify it. The more grainy scan is actually the ventilation, and the less grainy, rather defined picture is the perfusion scan. So this is a posterior view of the perfusion scan, and there is a defect in perfusion here. There is a defect in perfusion in the left upper lobe. So as we know, when the lung is abnormal, blood vessels, blood flow diminishes, and we know that the perfusion defect is because the lung is abnormal. And in the ventilation phase of the scan, what is happening is, this is the normal ventilation phase. The lung is aerated, bilaterally aerated. We know that on X-ray, the lung left upper lobe was aerated. But then in the delayed phase, where all the air in the normal lung has disappeared, there is retention of air in the left upper lobe. This is a posterior picture because the bronchus is not communicating with the proper tracheobronchial tree because of the bronchial atresia. Yeah.
Okay.
Next one.
Yeah. So this is a frontal chest radiograph of an adult patient, female. I think the lungs are overinflated.
Yeah.
And there are areas of probably emphysematous change to the upper lobe. And
you can ignore the lungs. You can ignore the bones and soft tissues.
Okay. So that leaves the vessels. So I think there's increased vascularity lower and less in the superior aspects. I think it's slightly less vascularity in the right upper zone.
It's fairly similar. Blood vessels are going. It's fairly similar.
So
in your review areas, what are the things that you look at when you report an X-ray, chest X-ray review areas, apieces, costophrenic angles behind the heart, and you always say something is normal. Trachea is normal, mediastinum is normal.
Yeah.
20.
And bones.
Yeah. So what about the trachea here? That's what I want you to.
Okay. I think a trachea is dilated.
Exactly. Yeah. So that's what when we say trachea is normal, mediastinum is normal, we should actually look at the trachea, and it's clearly distended in this case. And I'll give you the CT. This is a very rare condition. This is not my case. I took it from ACR. So this is actually distended trachea and distended bronchi in tracheobronchomegaly. The learning point is that look at the trachea and identify the luminal caliber of the trachea.
Okay. So this is a frontal chest radiograph of an adult patient.
Yeah, ignore the lungs, ignore the bones and soft tissues.
Okay. The mediastinum looks unremarkable. The trachea is not dilated. It's fairly central.
What about the lumen of the trachea? Is that a normal?
I thought it was fairly normal, but could it be slightly dilated then? Or narrowed even?
It's narrowed, isn't it? It's narrowed.
Okay.
So that's actually tomogram tracheal narrowing. Most common cause of tracheal narrowing, tracheal stricture is? It's very common, actually, very common. Especially nowadays in the second phase of COVID, we are getting quite a lot of patients.
Intubation or
exactly. Yeah, post-endotracheal intubation, prolonged endotracheal intubation is the most common cause of tracheal narrowing, tracheal stricture. It's a really tricky case to manage, and we're getting increasing number because of COVID. Patients has been on. That's their next set of suffering. Once they come out of intubation, they develop tracheal stricture. Okay, next case.
Okay, thank you. These are axial CT slices, lung windows of an adult patient's chest. So looking through them sequentially, I think the airways are slightly thickened and dilated.
Very good.
With the
diagnosis?
So I think this is bronchiectasis.
Very good. Yeah. So can you all see the signet ring sign? Yeah. So it's diagnosing bronchiectasis in the early phase is by comparing the outer diameter of a bronchus with its neighboring artery, pulmonary artery's outer diameter. Now you can see that the outer diameter of this bronchus is clearly wider than this pulmonary artery, and that appearance is signet ring sign. You can see widened pulmonary arteries, central bronchi on both sides, and this is early stage bronchiectasis. Next.
This frontal chest radiograph of an adult patient. So there are bilateral cystic or at least circular densities.
Very good. I'm quite pleased with that diagnosis. Yeah.
So this is also, I think mostly mid and lower zone. I can't see much in the upper zone. So I think this is bronchiectasis as well.
Very good. Yeah. So this is not LAM. This is not LCH. Is there any reason why you say the cystic capacities here are not LAM or LCH?
Why? So I think there'll be a lot more thing involved with LAM and LCH, I think.
Yeah. There will be a lot more cystic abnormalities in LAM, and they may involve the peripheral lung as well, whether this is more central. So for the benefit of others, I'm showing the cystic rounded opacities, cystic loosened opacities in the lung, and they're kind of predominantly central, mainly upper and mid lung, but there are also tram track signs. Can you see? Tram track sign, that may be a distended bronchus, a little bit of tram track sign. So you got the diagnosis. This is early phase bronchiectasis. Okay.
So this is a frontal chest radiograph of an adult patient. There's a portocath inside on the left side.
Yeah.
Multiple cystic areas bilaterally. I would say is more lower zone, but some in the upper zone as well, and tram track changes and early assays changes. Some tenting of the left.
So diagnosis is
in keeping with patient cystic fibrosis.
Yeah, cystic fibrosis is the pathological diagnosis, but the appearance on X-ray you can say.
No, sorry, it's
cystic You can say cystic bronchiectasis. Yeah. The reason why you use cystic bronchiectasis is cystic bronchiectasis connotes a more advanced phase of bronchiectasis. It's a later phase of bronchiectasis where the bronchi is so dilated they appear like big cysts. So you can say cystic bronchiectasis, and most commonly in a young patient of this age, cystic fibrosis is the likely diagnosis. So frequent causes of bronchiectasis, immune deficiency, cystic fibrosis, and idiopathic. Less frequent, we have all these causes, which I'm not going to elaborate. This is a very tricky one, so I'll just give you the diagnosis straight away. It's just a condition. You can see in the trachea, there is an endoluminal soft tissue nodule. So this is a tracheal and laryngeal papillomatosis, which manifests as multiple lung cysts as well as nodules in the trachea and larynx. You may get a case like this in the long case. So remember to keep this in mind. Do you want to have a go at this?
Yep. So this is a frontal chest radiograph of an adult female patient. Lung volumes are increased, and the hilar have been elevated bilaterally.
Is it hilar elevation or an apparent appearance because of the hyperexpansion of the lower lungs?
Okay, so it will be the latter then. But in terms of the lung zones, lung fields itself, I don't see any obvious mass lesions. So given that the abnormality is probably just hyperexpansion of the lungs bilaterally, bibasally, given that the lung vascular markings are less prominent, I wonder if there's some lower zone emphysematous changes.
Yeah. So how old is the patient?
The patient is quite young. So what is it called?
We'll give you CT. Let's see if that helps.
Yeah. So there's florid destructive emphysematous changes in the lungs bilaterally, and I just can't remember the name of the condition. Alpha-1 antitrypsin deficiency.
It is alpha-1 antitrypsin deficiency. So there is pan-acinar emphysema. What is pan-acinar emphysema? Involves the central and distal acini, and the appearance is no cystic spaces like centriacinar emphysema. It's just oversimplification of the lung architecture and pruning of the vessels. So this is how pan-acinar emphysema looks like, just oversimplification of the lung texture with pruning of the pulmonary vessels. And in this case, in addition to pan-acinar emphysema, there is also
bronchiectasis.
there is also bronchiectasis because alpha-1 antitrypsin deficiency causes pan-acinar emphysema as well as bronchiectasis. What is the type of emphysema in this?
This is subpleural.
Yeah, it's called paraseptal emphysema. Yeah, subpleural emphysema. Subpleural paraseptal emphysema, which is emphysematous spaces along the pleural margins. What type of emphysema is this?
This is centrilobular.
It is centrilobular emphysema, and you have seen so many cystic lung diseases. Can you all see the centrilobular artery inside the cystic airspace in the centrilobular emphysema here? This is not lung cyst because you can see a centrilobular artery. Are you clear on that? I hope rest of the people are also looking at it carefully. You can see the centrilobular artery of centrilobular emphysema, and there is no definable walls. Unlike a lamb cyst or an LCH cyst, there are no clear walls. It's just cystic airspace surrounded by normal lung. So what is the type of emphysema?
Centrilobular.
Very good. Emphysema types. Pan-acinar emphysema happens in alpha-1 antitrypsin deficiency. It is just hyperinflation and diffuse simplification of the lung architecture and pruning of vessels. It's difficult to diagnose until advanced as there is no surrounding normal lung. Centriacinar or centrilobular emphysema is emphysematous spaces with centrilobular artery in the center, no clear walls, unlike a lung cyst, and they have surrounding normal lung. Paraseptal emphysema, subpleural, and paracicatricial emphysema are adjacent to lung scarring, and they may have traction bronchiectasis. Can we start? Do we have candidate number 1 or number 2? Can you speak up, please? Number 1 or number 2? Can you raise hand? Number 2 or number 1? I was told that number 1 might leave early, so that's why I'm calling out for number 2. Perfect. Can you speak, please, number 2? Shall I unmute you? Has someone unmuted you, or do I have to do that? Can you give me one more raise hand signal, number 2? Because I'm struggling to locate you on the list of participants. Yeah, good. It should come up at the top once you raise your hands, but for some reason it's not coming up. Can you speak up, please, number 2? So you're not being unmuted yet. Can you speak, please, number 2? You have raised hand. Gosh. Let me just come out.
Hello?
Oh, yeah. Is that number 2?
Yes. Can you hear
Very
me?
good.
Yeah.
Very good. Yeah, I can hear you now. I'm supposed to unmute you, but there are so many participants. Your ID was not coming up. Yeah. Can you see the X-ray now?
Yes, I can see it now. Yes.
Good. You can start.
So this is the frontal chest skeletal with your patient. There's nothing caught my eye on the primary survey, but I can see what appears to be right paratracheal thickening.
Are you referring to this one?
No, higher. Yes, here. This paratracheal soft tissue convex shadow.
That's normal. No.
All right.
Are you referring to this one?
Yes.
I think that's the sternum.
All right.
Hmm.
So I'll continue to systematically
It's got
analyze.
bony density, isn't it? And it's kind of, if you can trace the ribs, you can see the rib and you can see the junction of costochondral junction. So that's how you subtract. You know, when you report a plain film in your reporting session, you might keep wondering, what is that? Is that significant? That's how my practice, how I look at, okay, that's kind of continuing downwards. It's got a margin that's bony. So I think that's a bony structure. I would ignore that.
All right. So I wonder if there are miliary nodules.
Very good. There are nodules. Why did you use the term miliary nodules?
Because they are tiny. They are all of similar 1 or 2 millimeter size.
They're all tiny. They're all discrete. Yeah.
And they're diffusely affecting the lung.
Very good. Yeah. So you can see them in the upper lung. Some nodules in the upper lung. And nodules in the bases.
Yes.
And they're kind of spread everywhere, suggestive of miliary nodules. And the diagnosis is?
So the first differential is miliary TB. Other differentials are miliary metastasis like melanoma or renal or thyroid.
Yeah. So that is the CT appearance of miliary, HRCT appearance of miliary nodules. Uniform sized nodules all over the lung, not sparing or predominantly affecting any particular area. Yeah, miliary nodules, and that's what the name comes from. Miliary TB and miliary histoplasmosis. Nodules are widespread, uniform size, discrete, which means they are not coalescing, and there are no septal lines, and the hyla are normal, unlike sarcoidosis. Now, multiple pinpoint opacities are all these conditions that causes metallic deposits in the lung, such as silicosis, stenosis, barytosis, post-lymphangiography, and alveolar microlithiasis. And I'm not sure if limestone workers, I don't know if we have that condition here at all. So multiple small opacities are miliary TB, fungal infections, CWP, sarcoid, subacute hypersensitivity pneumonitis, and fibrosing alveolitis, which is cryptogenic fibrosing alveolitis. So you know how to identify miliary TB. You know how to identify CWP, which are mid-zone ill-defined nodules. You know how to identify sarcoid, mid-zone nodules, ill-defined nodules, and large hyla. You know how to identify subacute hypersensitivity pneumonitis. You saw the case earlier. Mid-zone nodules, bit more discrete than sarcoid. There won't be any lymphadenopathy in the hilum, no pleural effusion. And fibrosing alveolitis are lower half and ill-defined nodules, multiple small opacity differentials. Greater than soft tissue density hemosiderosis, which can happen in mitral stenosis or pulmonary hemorrhage. They will have associated septal lines. Silicosis are mid-zones, well-defined and dense silica containing, and they may also have septal lines. Yeah, pulmonary cirrhosis is slightly lower density than silicosis. All these differentials, I'll just rush through this with lack of time. Yeah, okay, shall we go to the next case?
So, frontal hysterographic skeletal mature patient. I can see 3 abnormal areas. One is projected over the right mid-zone, right lower zone, and left lower zone. The right-sided abnormalities have a cotton wool appearance of airspace opacities. The left side looks like an lipidal bronchogram because the opacity is filling the tracheobronchial tree. I can see a central venous catheter in good position.
Yeah. What else can you see? What other iatrogenic device are you able to see?
Is there an esophageal stent?
Yeah. So there is an esophageal stent. So the purpose of this radiograph is similar to the previous migrated esophageal stent. Get your eyes to seeing esophageal stents and think about esophageal stents. So what could be happening in this case? Can you put everything together?
So maybe the esophageal stent is blocked and the patient has aspirated and infected and is getting IV antibiotics via the central lung.
So you put everything together now. So this is actually, when you in your GI postings or barium postings, you do get referrals for looking at patency of esophageal stents. And somebody who did a barium study, which the patient could not, which did not go into the stomach through esophagus, it got aspirated because stent is malfunctioning. So that's the diagnosis in this X-ray. So there is a malfunctioning esophageal stent, which has resulted in aspirated barium, and which is also causing aspiration pneumonias.
Yes.
Yeah, aspiration pneumonias. So which one to use, barium or gastrographin? So basically, the way I remember is that if you aspirate gastric acid or gastrographin, they both cause chemical pneumonitis. So gastrographin and gastric acid cause chemical pneumonitis. So in case of if you are suspecting aspiration from esophageal obstruction, use barium. Gastrographin is to be used when you are suspecting leak of esophagus, because if barium is leaked into mediastinum, it can cause severe mediastinitis or peritonitis.
Okay, so I can see bronchiectatic changes.
Yeah.
Predominantly lower.
So bronchiectasis, predominantly lower zone. Tramp track sign. Can you see tramp track sign?
Yes, bilateral.
Yeah. So that is tramp track sign. Get your eyes to seeing tramp track signs, which is quite diagnostic. When you see cystic lung conditions, you'll be wondering whether it's LAM or tuberous sclerosis or LCH. But when you find tramp tracks like this, then you are certain that this is bronchiectasis. So there is also small nodular consolidations, which are infections because of the bronchiectasis.
Yes.
So cystic bronchiectasis, HRCT. This is a case similar to what we have discussed, so I'll skip through it. Just a necrotic mass in a case of infection. So when you find this, think about immunocompromised patients, diabetes, alcohol abuse, drug abuse, etc. Acute cavitating consolidation or maceration. This can be an appearance in bronchogenic carcinoma. This can be an appearance in lung abscess. Look for air fluid levels. Yeah.
Yeah.
So this is actually a case of lung abscess because the CT shows the abnormality to be mainly inside the lung. Also, it's bordering on the mediastinum a little bit. It has got a smooth enhancing wall, air fluid level. So this is a lung abscess. When the lung infection proceeds to necrosis, it can form lung abscess. Yeah, do you want to do this case?
Yes. So I can see right lower zonal opacity on the frontal radiograph. On the lateral, this corresponds to anterior abnormality, although it does not follow the fissure, the oblique fissure. I cannot see the right hemidiaphragm, so this is right lower pneumonia. I can see fluid level posteriorly projected.
Very good. That's what I wanted you to pick up. So train your eyes to picking up air fluid levels on a chest X-ray. So air fluid level is actually seen in the frontal X-ray, in the PA view, as well as in the lateral view. There is another small abnormality here, which is
Fissural effusion.
Yeah, which is encysted pleural effusion.
Yes.
Yeah, that's the fissural in the fissure. Yeah, encysted pleural effusion in the right major fissure. Then there is low right lung consolidation, and there is air fluid level. So if you put everything together,
so it's probably a lung abscess.
Yeah.
Or maybe empyema.
Yeah. So how would you differentiate a lung abscess from empyema? Or how would you take forward a hydropneumothorax? This is hydropneumothorax, isn't it?
Yeah.
No, this is air fluid level. Now, how do you know if it's a hydropneumothorax, which is air and fluid in the pleural space, or air and fluid inside the lung on an X-ray? How do you take it forward?
Ultrasound would be very useful.
Right. Ultrasound may or may not show air fluid level. Inside the lung, you can't see it on ultrasound anyway, can you?
Sorry? I cannot see inside the lung, of course.
Yeah. If you had said CT, then nowadays we do CT quite a lot. So it should be straightforward CT. But actually, on the X-ray, there is a way by which you can differentiate the air fluid level, whether it's a hydropneumothorax, that is air and fluid pocket together in the pleura, or whether it's a lung abscess or a necrotizing lung lesion, that is an abnormality inside the lung. Do you know how to do that?
Yeah, maybe changing the position of the patient, lateral decubitus.
You're nearly there. So you do a frontal X-ray, and then you do a lateral X-ray. Now, if it is in the pleural space, the air fluid level, the width of the horizontal fluid level will vary in the frontal projection and lateral projection. So you can see that's a narrower width in the lateral projection. It's a wider width in the AP or frontal projection, and because of that, it's in the
pleura.
It's in the pleura. Very good. Yeah, it's in the pleura. It's not in the lung.
Yes.
Okay. So, do you want to comment on the CT? Can you identify the corresponding air fluid level that you saw on X-ray? Can you see that on CT?
Yes, there is an elliptical separation of the right basal pleura with fluid level and overlying consolidation, as well as
consolidation. There is fluid level.
Yes.
So what is this? What is this now? What's the pathological term for that?
It's an encysted empyema.
Yeah, it's an empyema. Yeah, because that's in the pleural space now. Now, there is something else that will tell you why this happened in this person.
So, okay, I will try to analyze the rest of the images.
Just look at the lung window.
Okay, so on the lung window, there is a fistula.
Yeah, there is. Very good.
Yes.
So what is that fistula called?
A bronchopleural fistula.
There is a bronchopleural fistula. Because of the extensive infection, the lung and the bronchial tree has broken down and is forming a fistulous communication into the pleural space, and that is why there is empyema there. So it's bronchopleural fistula causing hydropneumothorax and empyema. Yeah, so bronchopleural fistula. Chest X-ray appearance, persistent hydropneumothorax with air fluid levels asymmetric on frontal and lateral views. Central bronchopleural fistula usually post-op. Peripheral bronchopleural fistula can be from infection or inflammation secondary to underlying abscess, necrotizing pneumonia, bronchiectasis, and TB. Peripheral bronchopleural fistula can also be a mass, a malignancy that undergoes necrosis and breaks into the pleural space, or it can be barotrauma, where the lung explodes and forms a fistula into the pleural space. So you know what bronchopleural fistula is now, and look out for bronchopleural fistula when you find hydropneumothorax, and look out for the communication of the lung air or the bronchial tree. You may not actually see a bronchus communicating into the pleural space. You will only see a communication, a break in the lung parenchymal tissue in BPF on CT. So this is what I was telling about how to differentiate based on the width of the air fluid level. A lung abscess, whether you see from side or from the front, they'll have the same width, whereas an empyema or a hydropneumothorax, which is air and fluid in the pleural space, if you are looking at it from the front, they'll have a shorter width here, whereas if you're from the side, this will have a longer width.
Mm-hmm. So this is front of chest radiograph of a skeletal mature patient. I can see there is slight, the aortic knuckle is small. I know this is not the theme of.
Sorry, say it again. I didn't get that. Say it again.
The aortic knuckle is relatively small, but I know this is not the theme of the presentation. So
aortic knuckle is fine. In a young patient, you don't expect a big aortic knuckle.
Okay, so nothing caught my eye on primary survey, so I'm systematically reviewing the film. The mediastinal contour is alright. Yeah, there is right upper zonal opacity.
Yeah. So you cannot not pick up these opacities in the lung. That can be a cancer. That can be an infection. In this case, this is post-primary TB. This is a classical site of early appearance of post-primary TB, where you see in the upper lung a little bit of consolidation, which will gradually develop into cavitating consolidation and large cavities. So on CT, you can see nodules and inflammatory changes and tree in bud. I can see some tree in bud. Can you see the tree in bud here?
Yes.
Yeah. So small nodules budding out from a structure called tree in bud appearance.
Okay, so I can see bilateral multifocal patches of ground glass opacities as well as consolidation. There are also some fibrotic or reticular opacities, mostly in the right upper zone.
Now, the lung is undergoing a scarring process. You know that, isn't it?
Yes.
The lung is, the hilum is pulled up. I can see linear strands here. So this is undergoing a scarring process. Now, is the scarring process an interstitial fibrotic process, or is it a parenchymal destructive process?
I think it's more of parenchymal destruction.
Yeah. So what are the causes that results in this kind of parenchymal destructive process?
TB.
TB, yeah, very good. And
yeah, histoplasmosis, maybe.
Which we don't see in this country at all.
Yeah.
Sarcoid.
Sarcoid, yeah.
Yeah, yes, TB and sarcoid. So, yeah, can you elaborate a bit more? What is happening here?
So I can see, maybe this is a cavity.
Very good. That's a cavity. There is no lung markings there, vascular markings there. So that's a cavity, and there is a pulled up right hilum on, and this is right apical cavity. Quite classical for post-primary chronic TB. Okay.
So I can see hyperdense, very extremely hyperdense extrinsic or pleural-based opacity over the right upper zone. It looks like it's heavily calcified.
Yeah.
I can see that the overlying chest wall is abnormal. I cannot see any other pleural plaques.
So how would you put the diagnosis for this? It's a calcification in the
pleura, apical pleura.
Yeah. So calcified
pleural plaque.
Is this how pleural plaques appear?
Yeah, it's not the typical appearance, but I agree.
That's because it's not pleural plaque. Pleural plaques have typical appearance of leafy, edgy calciums with central lucency. This is a heavy, dense calcification in the pleural space, and you can call this a calcified fibrothorax.
All right.
Right? That's the term you can use for this. It's a dense calcified structure. Usually happens from TB, from infection, an empyema. A long-standing empyema will develop calcium along the wall. So a sequela of infection, a sequela of a traumatic big hemothorax, etc. So calcified fibrothorax. This is not pleural plaques. Please don't say pleural plaques. Yeah, you have seen at least 2 pleural plaques today.
All right.
Okay, that's a fibrothorax, calcified fibrothorax. Next one. Do you want to change, or do you want to continue? We have done.
Yeah, I would like to continue if you're happy.
Yeah. So we'll do. I think we have done half an hour for you, 12 cases. So to be fair, I think we should change to the next person. Is that okay?
Right. Yeah, it's fine.
Thank you.
Thank you.
Yeah. Can number 3 raise hand, please? Number 2, please mute yourself. Number 3, can you speak? Is number 3 here?
Can you hear me?
Yeah, I can hear you. Are you number 3?
Yeah.
Very good. Thank you. Can you start with this X-ray, please?
Frontal chest radiograph with bilateral dense opacities, especially on the right side. There appears to be cavitation within the opacity. The lung appears a bit emphysematous to me. There's a tenting of the both hemidiaphragms. So that shows that there's some fibrotic process going on. Mild interstitial thickening process, thickening as well, especially in the lower zones. So these appears more like a background interstitial fibrosis and bilateral mass-like lesions.
Can you see reticular opacities anywhere?
It's more scarring than the reticular opacities.
Exactly. This is a parenchymal scarring process.
Yeah.
This is not an interstitial fibrotic process. You correctly picked up the tenting of the diaphragm, and those lines are actually fibrosis. When lung scars, when there is inflammation after inflammation, there is scar tissue, and that's how it appears. Just pulls the diaphragm up, puts the diaphragm up. There is parenchymal scarring process. There is no reticulation at all There is no reticulation at all at the bases. And the basal volume is not reduced. You did say that the lungs appear hyperinflated and empty matters. So when you say the rest of the lung is hyperinflated, how can you put IPF in the differential? How can you put interstitial fibrosis?
Yeah, you're right.
Yeah, go ahead. Yeah.
So background scarring of the lung. Now these two bilateral hypertense lesions. Initially, I thought about progressive massive fibrosis.
Yeah, that's a good thinking, because perihilar large consolidation is the appearance of progressive massive fibrosis. But progressive massive fibrosis usually a bit more upper mid. That's a good thinking. Yeah, I don't. Yeah. Go ahead.
Other differential I was thinking of background lung infection.
Can you see air crescent sign here?
Yeah, I can see the air crescent sign, especially on the left side, which is very evident.
Good. So why didn't you say that?
So aspergilloma in background TB maybe is one of the differential, because lung is quite scarred. So
there is cavitating process. Yeah, there are multiple cavities with fungal balls inside.
Mycetomas.
Yeah, so you should say cavities. You didn't say that. I can't read your mind. The examiner will not be able to read your mind as well. So there are cavities with fungal balls and air crescent signs. So are the cavities in the upper lung or mid lung?
In the mid lung.
Right. So what are the differentials for cavities, fungal balls?
The cavities, the fungal ball can develop into previously formed cavities from tuberculosis, but here tuberculosis are typically upper lobes. The other differential would be vasculitis cavities, and then patients immunocompromised, and then developing these mycetomas in them.
Right. This is sarcoid cavities with fungal balls. Okay. If you see cavities in the center, think about sarcoidosis. And there is so much chronic scarring process going on. I wouldn't think of an acute abnormality like PCP pneumonia or invasive aspergillosis at this stage. Although you can mention that, but this is not the appearance of. I'll show you pictures of how the invasive aspergillosis cavities will look like. So this is chronic cavities, a lot of chronic scarring, and there are fungal balls in the cavities.
It's a frontal chest radiograph with a central line. I can see the central line in the patient, right-sided. The tip is projecting, I think.
Yeah, ignore the central line, that's fine.
So that means patient may be having a long-term chemo or antibiotic therapy.
Yeah. Pick up the abnormality in the chest, in the lungs.
In the left side of the lung, behind the heart, there is some.
Very good. You're all getting extremely good at picking up retrocardiac hidden area abnormalities. There is consolidation behind the heart in the setting of a probable immunocompromised patient on central line, and I'll give you the CT.
Yeah, so the CT is showing reverse halo sign.
CT showing what sign, sorry?
Reverse halo.
Reverse halo, is it?
Yeah.
It's proper halo. I mean, it's not reverse.
It's not reverse halo.
I don't know why you said reverse.
I don't know.
It's a halo sign.
Yeah, it's a ground glass opacity around the soft tissue opacity.
Exactly. Yeah, so there is ground glass opacity surrounding that nodule. Pulmonary nodule surrounded by ground glass. There is ground glass around that nodule. There is a little bit of ground glass here as well. So diagnosis is?
Invasive aspergillosis?
It is invasive aspergillosis. I'll just show you the magnified picture which shows ground glass around that nodule. Now, for a better understanding, I call it angio-invasive aspergillosis. Then I'm always thinking about angio-invasion and the hemorrhage and the pathomorphology. I usually say angio-invasive aspergillosis. So it happens in immunocompromised patients in severe neutropenia. It can also happen in immunocompromised with normal count, but they are immunocompromised because of heavy steroids. What happens is invasion and occlusion of small and medium-sized pulmonary arteries. resulting in necrotic hemorrhagic nodules with halo sign, or they can also result in pleural-based wedge consolidations, which are actually pulmonary infarcts. So multiple nodules with surrounding hemorrhage, halo sign, or multiple pulmonary infarctions. Those are the features of angioinvasive aspergillosis. Halo sign is nodules with hemorrhage. It can happen in angioinvasive aspergillosis, candida and mucorales infections, cytomegalovirus, and Kaposi sarcoma. These are, you might get a case of Kaposi sarcoma in your long case. So if you find nodules with halo sign, remember to keep that in the differential. Do you want to do this X-ray now? Next.
Yeah, frontal chest radiograph. The patient has got a center line in with the correct position. I mean, an endotracheal tube with the correct position. There are ECG lines up, but the main abnormality is bilateral air specification in both mid and lower zones.
Yeah. You can say they are consolidations because you can see air bronchograms within them, no?
Yeah.
Yeah.
So it's patchy consolidation bilaterally, or in fact rather diffuse, I would rather say, in both the mid and lower zones. It's quite typical of atypical bacterial infection. It could be there could be very different differentials. So atypical or viral infections, again there is a soft tissue nodularity with probably some air crescent sign.
Air crescent sign.
Yeah.
So there is air crescent sign on a background of extensive lung consolidation. Diagnosis?
Aspergillosis.
Yeah. So as you correctly identified, said earlier, air crescent sign can happen in acute invasive aspergillosis as well. So I'll show you. It happens during the resolving phase of active infection. What happens is, lung tissue is dead and necrotic. It forms a ball inside a cavity. So this is invasive aspergillosis, air crescent sign. And usually the air crescent in invasive aspergillosis surrounds the entire soft tissue, whereas the mycetoma or fungal ball is along the superficial part of the cavity. Now I'll show you the next X-ray, which is same patient 2 weeks earlier together. So there is quite a lot of consolidation in this radiograph, but no air crescent. And then the consolidation is resolving, and at that time the air crescent sign develops. So do you get it? Air crescent can happen in chronic fungal ball in a cavity. It can also happen in the resolving phase of invasive pulmonary aspergillosis in